This presentation will cover the SSDIs for breast cancer. My name is Lori Summers. I'm the trainer for the Iowa Cancer Registry. There are a couple of stopping points in this presentation at slide 40 and again at slide 60, depending on how much time you have to view. The breast schema is 480. The chapter in the AJCC manual is 48. Remember, there is an updated PDF of the breast chapter for TNM staging if you do not have the third printing of the AJCC manual. There are 21 required SSDIs. There is an updated version for SSDI manual, and that is 1.7. They have taken a lot of the questions in the cancer forum and inserted them into the manual for further clarification, and it is a huge help. So don't panic. I know it's a lot of SSDIs. We're going to kind of group them together and make our way through them. Here is the link where you can find the SSDI and grade manual. And then anytime there is a change to the manuals, it is a good idea to just browse through the change log, get an idea of what they have updated. And so I've posted that link there also. I will run through a few of these 1.7 updates that do relate to breast cancer. The rounding rules, these would be the general rounding rules, but once you get to the breast site in the SHRI or the SSDI manual, anything site specific would pertain then to the breast. So the rounding rules have been clarified for breast. The example given in the manual is these fields for HER2, single probe, dual probe, copy number, and the ratio. We are not rounding these fields. We are dropping that 100th decimal point if we would have that digit, and we are just simply coding what we have, the 6.7. Also notice the ER and PR percent positive do not have decimal points. So anything with a decimal point that does have to be rounded would be a full number up. So example 78.6% would be rounded up to a 79 or coded 079. So it depends on what field you are in if you're going to round up a whole number or if you're going to drop the 100th. So you just have to kind of identify where you're at. If you have a statement less than or greater than, again, this decimal field comes into play whether you have a decimal structure in that particular field or not. Examples at the bottom of this slide include the key 67. So if that was reported as greater than 20%, you would code 20.1. It's not that you are rounding, it's just you are taking the next possible number higher than 20%. Because there's a decimal in that field, you would go up by tenths. You can also see the ER and PR percent positive. If it's stated as greater than or less than, there are no decimals in those fields, so you are going to go up or down one whole number if that's what you have in your record. The timing rules are just clarified. We want to record any of the lab tests done before any cancer-directed treatment is given, so that would be neoadjuvant or surgical treatment, no earlier than 3 months before the diagnosis. If there are multiple tests available, record the highest value. Remember, these are general rules. So I'm already thinking of a couple of primary sites that this multiple test rule is different. This for breast, this is specific to breast in that it will happen a lot that you have possible multiple ER and PR. You might have one from the biopsy, you might have one from the mastectomy or lumpectomy. You want the positive or the highest value for the breast primary site. Okay, so we are going to just kind of group some of these SSDI together. I'm going to list them as they are in SEER RSA. So the numbers are out of order, the NACER numbers, but for clarity, it would go ER summary, ER percent positive, ER total all red score, and then same with PR. I've grouped all 6 of these together because the rules and the notes are identical, whether you're looking at the ER or the PR. Remember, don't use any results from any of the tests that record HER2, like Oncotype DX, MammaPrint, any of those. This should be on your path report. It's probably going to come as an addendum. This will not be like an Oncotype DX separate kind of a sheet or a consult sheet. For the sake of clarity, again, the ER and PR fields do correspond to the same notes. For instance, the ER and the PR summary, all of these notes are identical. Note 4 is updated in the SSDI manual for clarification. If you have invasive and in situ results, ignore the in situ results, code the invasive results. So if you have an ER or a PR summary and you've got both invasive and in situ in your tumor, you are going to ignore any of the results from the in situ tumor. If you have ER and PR positive on in situ and negative on invasive, you're going to code those as negative or code 0. If you have ER, PR that was only done on the in situ component and not on an invasive component, then you do need to code those as unknown or code 9. Once you have invasive, basically the in situ doesn't matter because the invasive is going to drive the prognosis, the treatment, and everything else. So ignoring the in situ is important because it no longer plays a portion of what's going to happen to this person. Okay, here's the rest of the notes. So I want to point out note 5 and note 6. Note 5 is if you have a single tumor, you have multiple biopsies, and you have different results for the ER or the PR summary, you're going to use the highest. In this case, highest means positive over a negative. Any of those results that are positive, you're going to take it. And then note 6, for multiple tumors, you could have multiple tumors in one breast. The ER/PR summary could be different. You're going to code from the largest tumor size, and that could be from your clinical or your path. But don't look at the specimen size. You want the largest tumor size. If there's neoadjuvant therapy given, again, make sure you're recording your ER/PR summary prior to neoadjuvant therapy. If you don't have results pre-treatment, you can report findings if you would have a post-treatment specimen. And then again, do not take any of these results from a multi-gene testing like Oncotype DX or MammaPrint. Here are the codes for both of these fields. So an ER or PR negative, if it states negative, or it could be 0%, or it might state less than 1%. That is still coded to 0. Otherwise, you would have a positive or an unknown if it was done. Okay, now let's look at the percent positive or the range for both the ER and the PR. Note 2 has been updated. Code using the same report as the ER PR summary. So you are going to have one report for all 3 of these data items for the ER, and that same report should also report out the PR. And so for all of these 6 initial fields that you are coding is going to come from one report. Note 5 also talks about if it's positive, but you don't know the percent, code XX7. Now, I looked in our software, we do have that code that was left out in the initial vendor software. And so if you don't have an XX7 available, then obviously you would code the XX9, but hopefully now you have the XX7 available as an option. For the ER and PR percent positive or the range, you want the actual percent positive. Take that over any range that you might have. If the ER or PR is negative, then you're going to code the percent as 0, 0, 0. Okay, so here's a few clarifications, and this happens a lot. If the ER or the PR is stated as negative, remember that could mean that it's either 0% or less than 1%. So you would still code this percent positive range to 0, 0, 0, but the all red score, you need to know what that percent is, and you don't have it. So the all red score is the X9 or unknown. If you have the ER PR stated as 0%, which is different from just stating negative, and the intensity is not listed, the percent positive or the range is assigned to 0, 0, 0, and your all red score is 0 because you can assume the intensity score is none. And this will all make more sense. We're going to tie all this together when we get a little bit further down the road. But I wanted to show you how important it is to code your ER, PR 0% if that's what it says, or negative if that's what it says. And then if you have a 0% and the intensity is listed of the ER, PR, then you're going to be able to calculate your all red score down the road. So you do need both percent positive, which we have here in the second and third option, and you need the intensity in order to calculate the all red score. In this first option up here, we only knew ER or PR is negative, but we didn't have a percent. So as you're texting this information, make sure that you are getting that texted clearly. Okay, so what is the all red score? Here's the notes for either the ER or the PR all red score. This is a prognostic score. So we want to use the same report that we have been using to code the ER, PR summary and the percent positive. This might be in your CAP summary. On the CAP protocol, all red score is a separate form that is an optional. So don't be surprised if you're not finding this or if your pathologist is not giving it to you. It is optional. I had a pathologist tell me I'm not going to do it. It's optional. He gives you the components that you can calculate it, but he's not going to report out what the all-red score is. Note 3, the all-red system is looking at what percent of cells test positive for either of these hormone receptors and how well they show up after staining. So we again need that percent positive and we need the intensity. Then you combine those and you're going to come up with a score from 0 to 8. Again, you cannot calculate it if you don't have both components. On page 174 in the SSDI manual, you will find the calculation tables for all-red score. These are not located anywhere else. So you might want to bookmark that. You might want to print it out, tape it somewhere so that you have it handy. If the ER and PR were performed, but you cannot calculate the all-red score, then your score is going to be X9. So here's the tables that you need to calculate the all-red score. And like I said, you need the percent positive, cells, and then you need the intensity. So as you look at this, these are the kinds of things that you need to text off of your ER and PR report. You are going to look down to the range. So say your ER is 90%. That falls greater than 67. So you're going to grab the 5. And your intensity is intermediate or moderate. You're going to grab the 2 and you're going to add those together. 5 plus 2, your all-red score would be 0.7. So those tables right here are only found in the SSDI manual. They are not in SEER RSA, which is where I kind of keep open for my site-specific rules. I think they may have finally linked to this area, but keep this handy. You're going to need this when you get to that, these two ER and PR all-red scores. Okay, and then here's your codes. We had a 7. Our score was 7 that we added up, 5 plus 2. So our code was 07. Okay, here's a pop quiz. This text, when I do quizzes like this, I want you to look at what is texted. Specifically, not just using it for the quiz, but ask yourself, could I text this better? What would make more sense? What isn't texted that I wish I knew? So use these as examples also, not necessarily as good or bad texting, but this is the kind of information that you're going to be coding from. So that's why your text needs to be very, very specific. In this case, the ER and the PR are positive. We do not have the percent positive, but we do have the all-red score. So you can't back calculate it either. You could only calculate the all-red score. So let's go through this. The ER summary was positive. So that's a 1. And then the ER percent positive, we know it was done. We don't know what the value was. And then the ER all-red score was given to us. We don't even have to calculate it. It was 0.8. And then the PR summary is also positive, so that's a 1. The PR percent positive we do not have. So again, XX7 would be test done results of the percentage not in the chart. And then the PR all-red score was given to us and it is a 0.8. Okay, so let's calculate a couple of these all red scores and see what we have. If you need to look back, I think it's slide 15 for the all red table to figure these out. Remember, we're looking for two things in the text. We need the proportion score. So in this example, we have ER 100% positive, and we also have PR 100% positive. But we also need the intensity. So those words back on that table, what were they? Weak, intermediate, moderate, strong. I'm not seeing that anywhere in relation to the ER or PR. So at this point, if I thought I texted it, I would go back to the chart and see if I could find it again, just to make sure that I didn't miss texting that information. So then 100% has a score of 5. And because we don't have the intensity, we can't add the 5 to anything. So our ER all red score has to be X9 because we cannot calculate it. We don't have enough information. So looking at the PR, basically the same thing. We know it's 100% positive, which would be a number 5 from our table, but we don't have the intensity. So again, this would have to be X9. Look up in the HER2 text. This does say weakly positive. However, this is not what we are looking for that intensity score. That is for the HER2. We need an intensity score for the ER or the ERA and the PRA. So you can text this either way, estrogen receptor ER or estrogen receptor assay is what that means. And then same with PR. And POS is perfectly fine for positive. I try to stay away from texting parenthesis plus sign parenthesis because if by the time you do that and shift through all of that, you could type POS. And just using simples is hard sometimes if it runs onto a different line. So this is much clearer, a clearer way to text. Okay, so let's look at another one. This one, the text provides both the proportion score and the intensity for the ER. So let's do the ER first. The ER summary is positive, so that's a 1. The ER percent positive is stated less than 95%. So the general rules in the SSDI manual tell us to go 1 less than that. And so when we looked at the SSDI changes in the manual, those were the general rules. However, it did apply to breast. So remember, there are rules other than what is in the site-specific rules in SHRI RSA. Your drop downs are not going to have those rules. You need to know where to go to find those. The all red score, then we have less than 95%, but we know that is still higher than the cutoff of 67%. So that would be a 5. And then we have strong intensity, and that would be a score of 3. So we're going to add those together, and our all red score for ER is 0.8. You can also see those are not always going to be the same, the ER and the PR all red score. Sometimes they are, but they don't have to be. For the PR, it was stated as negative. And we don't have anything else. We don't have an intensity, but looking back at slide 12, We do know that a statement of negative allows us to code the percent positive range as 0, 0, 0. So we're going to code PR summary as 0. And then note 3 is allowing us to code this to 0, 0, 0. Actually, it might be slide 11. Sorry. If you want to look back. And then there's no positive, percent positive, and there's no intensity. We can't calculate this because we don't have both of those. So that will be X9. Okay, let's look at one more. This text was in the lab section, so this is where we want this information. Although this comes on a path report, all of this text in the lab section is helpful. You're kind of pulling it out of the path report or the addendum, put it in the lab section. So our ER is positive. It's 95% positive, and we have 3+ strong intensity. So our ER summary is positive. It's 95%. And our all red score is going to be the two scores of 5 plus 3, so greater than 67%, and it's strong. So our all red score for ER is going to be 0.8. We will then look at the PR, positive at 90%. We also have a 2+ moderate to strong intensity. So looking back again on the table, moderate to strong is 2 different categories. So we're either going to have the intensity score be a 2 or a 3. And in the forum, it tells us to code the strong when you have a range of intensity. So if it was moderate to strong, you're going to code the highest. You could also have a variable intensity, and it might say weak, moderate, and strong intensity. For that one, you're going to code it to a strong. So our all red score on this one would be an 0.8. All right, so we've already knocked out these first 6 SSDIs. Remember, you're collecting both the ER and the PR off the same specimen, and then texting this information together in the lab section. Okay, so other references that are available, the Cancer Forum has really good information about the SSDIs. The NACER breast webinar back from 2019, it did use the updated 1.7 version of the SSDI manual. We do have those available. If you would like to watch that, let Bobby or myself know, and we can send you the video and the documents for that webinar. Also, NACER is the standard setter for the SSDIs. So they are in charge of the manuals, the updates, and so being able to find these references is helpful. Okay, so the next 6 of the 21 SSDIs pertain to the HER2 status. So read the fields carefully. It's very easy to mix these up. And I always just confirm the NACER ID number when I'm going into these to make sure, because your software might be in a different order than what you see on SEER RSA. And so just clarify that you are in the right HER2 field. The HER2 results are recorded from an IHC or immunohistochemistry or the ISH test only. So the ISH would be like a FISH, a KISH, a CISH test. That's what you need for the HER2 fields. Remember, we are not using results from an Oncotype DX or a MammaPrint, any of those tests like that. It has to be from an IHC or an ISH. So the breast HER2, this is an epidermal growth factor on receptor 2. So this is down to the gene level of what they are looking at to see if this gene is overexpressed or not. 15 to 20% of breast cancers are HER2 positive. They have an overexpression of HER2. There is a worse prognosis in both node negative and node positive patients if the HER2 is positive. So this determines the eligibility of the anti-HER2 therapy or Herceptin, which you've probably heard of. And in order for them to get Herceptin, the patient has to be HER2 positive, meaning that their tumor is showing an overexpression of the HER2. So there's 9 notes for the HER2 overall summary. Mainly I want to look at 4. If you have invasive and in situ results, ignore the in situ. If you have HER2 positive on an in situ and HER2 negative on the invasive component, code the HER2 as negative or code 0. If you have HER2 only done on in situ, but you have both in situ and invasive present, you're going to code unknown or a 9 because you don't know what the HER2 status was on the invasive portion. Note 5 and note 6 separate out again the single tumor versus multiple tumors. If you have a single tumor and you have multiple biopsies with different HER2 results, code the highest or positive over a negative. If you have multiple tumors in the breast, you have different HER2 results, code from the largest tumor. Okay, so simple codes, either you have negative or positive, or you don't know. So here's the HER2 by IHC summary. So there are going to be different HER2 tests. The first one that they're going to do is a HER2 by immunohistochemistry. This is performed on primary breast tissue, not the lymph nodes. You can use the results from nodal or metastatic tissue, but only when there's no evidence of primary tumor. That doesn't mean no residual. That means you have METs and they've defined it as a breast primary, but they cannot find a primary tumor in the breast. Note 4 says ignore in situ results. You're not going to code this on an in situ. Again, note 5 and 6 do the same thing with the single tumor and the multiple tumors. So be careful when you have multiple results to look back up and get the right rule. And then note A, if you have a 2+ or equivocal finding by immunohistochemistry, that should be a flag for you to look for more additional testing with a FISH to determine the gene copy number. So that this initial HER2 by IHC, if it's negative, they're not going to do a FISH. If it's equivocal or positive, they're going to go on to do a FISH. And so here are the codes. And you've got a couple different codes For negative, you've got a score 0 could be a negative, a score 1 plus could be a negative. You also have code 4. It might state HER2 IHC negative, but not give you a score. So at least you have the option of coding a negative. So look at the scores here for a minute. Anything that is reported out as HER2 1 plus or HER2 3 plus, you can assume that if they give you a score like this, they are talking about the HER2 immunohistochemistry. They might not tell you HER2 by IHC 2 plus. They might just say HER2 2 plus. Like I said on the other screen or the other slide, if you have a HER2 by IHC equivocal or 2 plus, that means it's indeterminate and they're going to do a FISH. If you have a positive or a 3 plus, they're going to do a FISH because then they need that gene copy number. Okay, so let's look at the HER2 issues. These could be FISH, KISH, or SISH. I would say the FISH is probably the most common of what most people see. This is the in situ hybridization. You might have a single probe or you might have a dual probe. And so there's some tips to kind of knowing what to look for. If you have a single probe, you're going to look for a copy number or signals, but you're not going to calculate a copy number. But you're not going to have a ratio. There's no ratio on a single probe. They've only done one probe. If you have a CEP17 or another control might be the D17Z1, this is a dual probe. So they're going to do a HER2 probe and they're going to do a control probe. Often the CEP17 probe. So then they're going to come up with a ratio. Again, you want to look for the HER2 copy number, but we're not going to calculate a copy number. They should give that to you. So remember, this is not the same field as the IHC. This is the ISH. So the FISH could be negative or not amplified. It could be positive or amplified. Rarely I would expect the FISH to be equivocal. You're trying to rule out if that equivocal IHC is positive or negative, and usually they can do that on a FISH. Also, remember, this is only going to be done if the IHC is borderline or positive. If that initial HER2 by IHC is negative, they're not going to do a FISH. Okay, so looking at the notes for the dual probe ratio, remember, you're going to have two things going on in this report. And so this is going to be a FISH dual probe ratio. Could be the KISH or the SISH. We don't typically see those, but you might. But use the same report for your dual probe ratio and your copy number. You might see this term, the ERB2. That's actually what the gene is, but typically it's reported out as a HER2. Do not round this field. If you have the 100th decimal, you're going to drop it and just code the 1.9. So we are looking for a ratio for this field. Also, we are not calculating the ratio. They need to give it to you. So it's going to be a low number. We want the actual number over this general term of less than or greater than 2, if you have that. Okay, so let's look at the copy number. This could also be called signal, dual probe copy number, or dual probe signal cells. Both of these fields are from the same report. And remember, to tell the difference between a single probe and a dual probe, you're going to look for the mention of that SEP17. Do not calculate the copy number. Also, and I'll show you some examples, you will see the copy number for the SEP17 also reported. You're looking for the HER2 copy number. So don't be confused on that, because it's confusing. Okay, so let's just look at some examples of reports. This is a SHRI lab report. This information is going to be texted in your lab section. Do not text every single thing in this report. It will be way too much. It's too confusing. So first ask yourself if this is a single probe or dual probe. I've already given it away, but it's a single probe. Okay, never mind. I'm already confusing myself. Okay, so because we have a ratio on this one, we do have a dual probe, and it is giving us the ratio, and we have SEP17. That's about the only way that we know that we have a dual probe. So now we need to look for the copy number of the HER2, which is 4.26. And we have the ratio of the 1.3. Remember, we're not rounding up, so we're going to drop that 6 off of here, and we would code the HER2 copy number as 4.2, and our dual probe ratio would be 1.3. You can see here where it says the HER2 to SEP17 ratio is 4.26 over 3.13. If they did not give us the ratio of 1.3, we are not allowed to calculate this. Okay. Also, we want the HER2 copy number of 4.26. Here is the SEP17 copy number. We do not need that. We don't need to text it. All right, well, I've got some more examples coming up. So the HER2-ish single probe copy number, all you're going to have is the copy number. You're not going to have a ratio because there's not 2 probes. Remember, ignore that 100th decimal and don't use results from the Oncotype DX. They do report out HER2 fish on the Oncotype DX. That's not the report that we want to take it from. Okay, so here is an example of a single probe copy number. I thought I had a copy of that. So there's no ratio mentioned. There's no SEP17. So look for the average number or the HER2 copy number on this one. And we have a single probe. and we have a copy number of 6.9. I have never seen a single probe report. I've only ever seen the dual probes. But this is what it would look like. And really, in your text, what I would text would be the date and then HER2 by fish. And then the HER2 copy number 6.9 is what I would text. And I would put HER2 by fish positive, because this is positive. Okay, here's an actual fish report. Again, you do not need to text everything on here. The first thing I want to know is if I have a single probe or a dual probe. And I have a ratio, so that tells me I have a dual probe. So really, 3 things. Like when I'm texting this, I want 3 things. HER2 by fish negative, HER2 fish ratio 1.35, and we should have a HER2 signal of 2.8. That's the 3 things I would text off of here. Do not text the SEP17 signals, which is right below the HER2 signals, because you're not coding that. And so they've actually given you the ratio in 2 places here, down here below the copy number or the signals, and then up here is your ratio, the final ratio. Okay, so here's one more example, just looking at what we want off of this report. So the HER2 by fish is negative. We do have a ratio, so we know it's a dual probe. And the HER2 copy number is 1.80. We do not want the SEP17 copy number. This is just a good example too, that you can see you have a dual probe. You have a red probe and a green probe. That's 2 probes. But basically you want HER2 by fish negative, you want the ratio, and you want the HER2 copy number. That's all you need to text. Okay, this is a good point if you want to pause and look at the next 5 quizzes that are here. You can work through those on your own, or if you want to just keep powering through, I will go through all of the answers on this quiz and just kind of the rationale of how to find this information. All right, let's go over the 5 quizzes. These were just examples of texting and of learning, getting some confidence in coding these fields. This is an area that causes a lot of confusion. I think part of it is the naming of the fields, and part of it is knowing what report you're looking for. So the first thing to note, the HER2 was done. We do have a fish. We do have a ratio, just to kind of get some bearings on what we've got here. Even though we don't have a SEP17 listed, which you don't need to in your text, just by the word ratio, we know this is a dual probe. So we will not code this single probe copy number in this exercise. If the fish was done, the overall summary and the ish summary are typically the same. Remember our rules about less than or greater than. And if you need to code that also. So we have We don't have that in this example, but we might have that coming up. Okay, so let's code this. HER2, the overall summary. So this takes into account the fish, and the fish was negative. So the overall HER2 summary is 0. The HER2 IHC, the HER2 immunohistochemical chemistry summary, there was no score given, but it was stated as positive. So the HER2 new was weakly positive. So we know that is a 3. The code 3 is used for positive 3+, but it's also used if it just says stated as positive. So that's a 3. The HER2 by fish was negative. That was one of the 3 things we need to text off of the fish report. And then we do have a HER2 ratio of 1.2. We have, we do have a less than 4 signals on the HER2 copy number. And so because this field has a decimal, we will go down to 3.9, code 1 less than the 4, and you have to look at the field to see if there's a decimal in there and go down 1 option less than what you have. And then there's no single probe copy number, so that will be XX9. So again, look at the ways these things are texted. Typically, I like to put HER2 by IHC for my text, just so that it makes it clear for me when I'm going back to look how to code that information. All right, let's go on to quiz 2. This was the addendum to the path report. First, look to see if you have a single probe or a dual probe. The SEP17 confirms that you have a dual probe. And then we look for the ratio, which is stated to be 3.2. We do have 2 signals reported in this one. We have the HER2 signals and we have the SEP17 signals. So hopefully you can see that's confusing. You don't need the SEP17 signals. Per note 2, a dual probe test will report the average number or mean signals for both the HER2 and the SEP17. We want the HER2 signals. Think of the SEP17 as the control and how you end up getting your ratio. The fish summary and the overall summary, again, is going to be similar. So the fish this time was positive. The HER2 by IHC was 2+ equivocal. The HER2-ish summary, even though it's positive, the fish is positive, it's a different code. So don't think that your HER2 overall summary and your HER2-ish summary codes are going to be identical. Be careful with that. The ratio for our dual probe is 3.2, and our HER2 copy number is 5.4. And then we don't have a single probe copy number. Okay, quiz number 3. Ask yourself first, is this a single probe or a dual probe? We do have a ratio, so it's a dual probe. Also note the last sentence is giving a summary of the results. So as this person was texting the fish, starting about the 4th line, texted all of this information and then got to the bottom and said, this fish is negative. So the overall result is negative. The HER2 overall summary is negative. The HER2 by IHC, and it was texted clearly here, is 2+ equivocal. That means I should look for a fish. The HER2 by fish is negative by that very last sentence at the bottom. And then we do have a dual probe, so our ratio is 1.3. And our HER2 copy number is 2.5. We do not have a single probe copy number. Okay, quiz 4. Again, looking for a ratio. We know this is a dual probe. We also have texted a SEP17, just confirms that you have a ratio. The HER2 fish was negative, so the overall summary is negative. The HER2 by IHC again is 2+ equivocal, so I should have a fish, which I do. The HER2 fish summary is negative. The HER2-ish dual probe ratio is 1.2. We're not going to round, we're going to drop that other digit. And then the HER2 fish does not tell us this is the signal or the copy number. I would like to see that texted, but because the way this is texted and after seeing several reports, I would know that this 3.3 is the copy number or the signal number. And no single probe copy number, so that's an XX9. Okay, last exercise. Again, we have a ratio, so this is a dual probe. There are a lot of reports or a lot of results given in these reports, which we saw on those fish reports. So key in to the HER2 fish number, not the SEP17 number. This is kind of an interesting way to text this. Again, not ideal, but I think you can figure out from what we've looked at what needs to be texted. So the HER2 overall summary, the HER2 by fish was negative. The IHC summary was equivocal. That's why they did the fish. The fish was negative. And then we need the ratio is 1.2. We're not going to round. The dual probe copy number. So the HER2 fish 2.6, I would say, is the copy number. Again, we're not going to round it. We're going to drop that 100th digit. The way this is written and comparing these two, I would say this is the copy number for the HER2. This is the copy number for the SEP17. There's probably some things in this text that you don't need, or in some of these examples that you don't need. Again, personally, I would not text the SEP17 copy number. You're not using it. It's a little confusing. Why put in more information that you're not coding? Just remember to text clearly, text concisely so that you don't get confused. The best practice is to text your information first and then go back and try to code from your text. So this practice just makes it easier when you get to the SSDIs. Oh yes, single probe was not done, so XX9 on this one. Okay, let's take a deep breath for a minute. If you have questions as we're going through this, I realize it's recorded, but jot them down, email me. I've got my email at the end of the slides. We're almost through all of the SSDIs for breast. We've gotten through the ER/PR, and we've gotten through all of the HER2 data items. So there's just a few HER2 fields left. Let's look at the Ki-67. This is a marker of cell proliferation. How fast or how proliferating is the tumor? How is it dividing? How quickly is it dividing? You can use results from the METs from a lymph node or metastatic tissue. Again, only if there's no evidence of primary tumor. So typically you want this from your primary tissue. This is reported as a percent. So that's what you're looking for, is the Ki-67 or the Ki-67 percentage. This will also be texted in the lab section. So here's the basic codes. The percent does take priority over the other codes. If you have 14%, you would code it as 14.0. 8% would be 8.0. A lot of times you'll get a Ki-67 as a range. And so you can see that our options don't even have ranges. You would code from the lowest number in that range. So if you had the range of 5 to 10%, code one number above the lowest number. So you would take this to 6% or 6.0. If you had less than 16%, because of our rules of less than and greater than, you would go down to 15.9%. Okay, the Oncotype DX tests. We've talked about those a little bit. We do not use any information for any of the other SSDIs from these tests. These are specific. And you will see that 2 of these apply to invasive and 2 apply to DCIS. So you're not going to have all 4 coded. You're going to code 2 if you have invasive. You're going to code 2 if you have in situ. The Oncotype DX test is a genomic test. What they're looking for is the likelihood of a local recurrence, and depending on the results will help evaluate what kind of treatment they need. So these 4 fields are kind of tied together. Here's the notes for Oncotype DX score invasive. You're looking for the score on the report. It's pretty clear. It's a special report. It's not going to be a dictated report. Or if you find this in a physician, maybe a summary, he will say Oncotype RS, recurrence score 20. That would be the number that you're looking for. If you don't have that report, then you're going to code the XX9. And so here are the scores that you're looking for the invasive. You also might have I wanted to get to the XX4 and XX5. If you have less than or greater than 11, you can still code this if you don't have an actual score. Also note, if you're coding an in situ case, this field does not apply. You would put XX6 here because you have an in situ case and you're going to code it in the in situ fields. Okay, so then you also want to look for the risk level. From that score, they give you a risk level. You can see here, if you don't have the risk level stated, low, intermediate, or high, you can take that score and plug it into one of these, and you can still code the risk level. So that way you can have both of these. You will have the score and the risk level. It's either going to be for the invasive or the in situ. Okay, so same concept with the DCIS. The in situ, you're going to have an Oncotype DX report. It's going to tell you that if you have an invasive case, this will be XX6 because you're not going to code it here. You're going to code it back on the other two fields we just looked at, which would be for an invasive case. Also, if all you have is a lobular carcinoma in situ, or LCIS, you are going to code this to XX9. This does not apply because they're only looking at DCIS. So if you don't have DCIS, you can't code that here. It has to go, it has to be coded XX9. Okay, and then here's the risk level. Again, if you're working with an invasive case, you're going to code this as not applicable because you've got two other fields to code this for invasive. But same concept, if you've got the Oncotype DX risk level score and you don't have the risk level, you can plug it into these 0, 1, or 2 and go by your score that you have. Okay, there might be another type of test that they've done that's not an Oncotype DX. So for anything else that's not an Oncotype DX, you've got two fields that you can fill out. Typically, these are done on node negative cases. They want to predict the recurrence or the response to chemo. Only record the test done on tumor tissue that might help determine if the cancer is likely to recur. So these would be like MammaPrint, some of the other tests that you might see at your facility. Remember, these are multi-gene. So this would not include BRCA, that's one gene. It would not include MyRisk. That's kind of that supermarket genetic test. This is a multi-gene test done on the cancer tissue. Okay, and then response to neoadjuvant therapy. Make sure you're texting this information and who stated the response. We need the physician's statement of how this person responded to their neoadjuvant therapy. This does include systemic or radiation administered prior to surgery. We cannot infer this or interpret this. We need them to state it. So review the medical record for a specific statement about the response. Response is based on not just the path report, but imaging and clinical findings. That's why we need the treating physician to pull all that information together and tell us what the response was. If you have in situ tumor or a behavior code of 2, neoadjuvant therapy is typically not given. You're going to code a 0. You could code a complete response if it's stated total or complete by the physician. Otherwise, you're not going to code this. Okay, and so the SSDI for regional nodes, level 1 and 2 are coded here. You want microscopic information only. If there's no ipsilateral nodes examined or anything in the drainage area removed, and they tried to remove axillary nodes but couldn't find anything, you're going to code X9. Remember, for isolated tumor cells for breast, those are negative. So we'll look at this more when we look at regional nodes in the actual breast training. This is a specific SSDI just for positive under the microscope, pathologically confirmed level 1 and 2 lymph nodes, not clinical. Again, anything that says isolated tumor cells, overall for breast, those are not positive. Also keep in mind there's a checks and balance with this field and the regional lymph nodes positive and examined. If you do have positive axillary lymph nodes, the number positive in this field has to be less than or equal to regional nodes positive. This will always be a subset of that overall regional nodes positive field. So here's the basic codes. We're counting lymph nodes, how many were positive. Okay, one more pop quiz before we take another short break and talk about grade, and then we'll finish up. So just looking at all of the fields now that we've talked about for the SSDI, you can see that we have an ER/PR on both the biopsy and the mastectomy. I did add the procedure here just so you could see what was done. There is no neoadjuvant therapy between these two procedures. The ER and PR was done on both specimens. So, which do we take? Note 5 states in cases where there's a single tumor with multiple results, use the highest, so positive over negative. Both of the path specimens were invasive, so we can't rule that out that one of them was in situ. There isn't a lot of text here, but we should be able to code most of these fields. Remember to text clearly, use punctuation, and let's just work through this one. So the ER/PR was negative on a stereo needle biopsy. When they did the mastectomy, the ER was positive and the PR was negative. So we are going to take the positive over the negative. We have one tumor here. We don't have multiple tumors. So we don't have to worry about the size of the tumor. We know this is the same tumor, single tumor. So our ER summary is positive. Our ER percent positive was 16%. Our ER all red was stated as 04. Our PR in both specimens was negative. We did have a percent of PR negative less than 1%. In note 3, that says to code it to 000. And our PR all red was 0. That should be 00 for a 2-digit field. Okay, and then the HER2 overall summary. We did have a HER2 by IHC was negative, but our HER2 FISH was positive. So our overall summary is positive. Our HER2 by IHC was negative, 1+. Our HER2 FISH summary, again, that's positive. And we have a ratio, so we have a dual probe ratio of 2.2. We have a HER2 copy number of 6.4. We did not have a single probe, and we do have a Ki67 of 44. So there's our, the best that we can do for this case for what we have for text. All right, that's how to dig through those SSDI reports. Grade is considered a SSDI. The remainder of this presentation will be on grade, so if you want to pause or if you need to leave, I understand. This is basic, it's from the grade manual. So we'll just kind of walk through the grade rules for breast, specific to breast. These grade rules are active for 2018 to 2020 diagnosed cases. Starting with 2021 diagnosis, there is going to be an additional grade field added, and we're going to talk about that next year. So remember, grade clinical. This is the grade of a solid primary tumor before any treatment. It cannot be blank. You want the highest grade from the primary tumor during the clinical time frame. So this does include a core needle biopsy, a stereotactic biopsy, or even a fine needle aspirate. If there's only one grade available, and you don't know if it's clinical or path, you're going to assume that it's clinical. All right, and then grade path. This is the grade of the solid primary tumor. It has to be surgically resected. It has to meet the guideline requirements in AJCC for a surgical resection. No neoadjuvant therapy has been given. You can use all the information, including clinical staging, through surgical resection. So you want to record the highest grade from any microscopic specimen of the primary site, whether it's clinical or surgical. So think of this as it's the grade for the patient, not just the specimen. The surgical resection has to be done in order to carry a higher clinical grade forward. So if there's a resection done of a primary tumor and there's no grade documented from the surgical resection, you can bring down the clinical grade into the grade pathologic field. If there's a resection done of a primary tumor and there's no residual, then use the grade from the clinical workup. This cannot be blank. Okay, grade post-therapy. This will be the grade from the solid primary tumor that has been resected after neoadjuvant therapy. This corresponds to the YP staging period only, and it has to meet the surgical resection requirements in the AJCC manual. So you're going to leave this blank if there's no neoadjuvant therapy, if it's a clinical or a path case only, or if you only have one grade, you don't know what it is. Again, our rule is to code that into the clinical. Breast uses the grade table 2. This is important because it does have different letters and numbers. So for invasive cancers, there are certain codes, 1 through 3, that are going to take priority over the generic A through D. If you have in situ cancers, codes L, M, and H are going to take priority over that generic A through D. So here are the codes on the table for both the invasive and the in situ, with the priority for each. It's very important to code the grade of all the DCIS. If you know your pathologist always use Nottingham, then text that as you're abstracting and texting your path information. So look at the bottom of this table, and because you have the letter options A, B, C, and D, that gives you permission to go to the generic grade table if you need to still code grade. A lot of the grade tables do not have the option A, B, C, or D, so then you do not have permission to go to the generic grade table. That's what you need in order to convert your grade if all you have is well, mod, or poorly diff. So the generic grade table is on page, I think it's 32 or 33. It's in the grade manual. You can only use the generic grade table when the appropriate grade table for a cancer uses the generic categories like A, B, C, or D. So we just looked at that on the grade table for breast. It does allow the A, B, C, or D. So then you would go to the generic grade table. And the example I've given you here is if you have a mod well diff ductal carcinoma of the breast. That does not fit in any of the options up higher, because up higher you have the Nottingham grade 1, 2, or 3, and then you have the in situ nuclear grades. And so you would need to go to the generic grade table to find this. Mod well diff is grade 2, which you can see on this little excerpt of the grade table. There are more pages to this. I just pulled out for this example. And you would assign a grade 2 mod well diff to a B. And since you have that option in your grade table for breast, then your code for grade would be a B. So here's just a few grade exercises, very simplistic, of what we can walk through here. So the biopsy, we know they had a right breast cancer from the biopsy. There was no biopsy report at your hospital. They came to your hospital for a mastectomy. So then on 2/1, they had a right breast mastectomy. They have an invasive ductal with a G3, grade 3. We have also extensive DCIS and a score of 8. So that would be a Nottingham score of 8. We do not have any clinical information on grade. So grade clinical would be a 9. We will take the G3, the grade 3 from the mastectomy. So the grade path would be a 3. The grade post-therapy would be blank. So we are going to ignore the grade from the DCIS and always take the grade from the invasive. Okay, I would consider the text on this exercise number 2 as pretty close to ideal. In the core biopsy, you know that it's Nottingham grade 1. So you may know that all of your breast path grade is Nottingham at your hospital. We don't know that. We don't keep track of what mechanisms your hospital uses. So if you would text that information, it just makes things so much clearer. So here we have in the biopsy, Nottingham grade 1. And then in the lumpectomy, we have Elston Ellis, or also means Nottingham, grade 2, with a Nottingham score of 6. So the clinical grade is going to be a 1 from the biopsy. The grade path is going to be a 2 from the lumpectomy. And obviously, grade post therapy is blank because we do not have any neoadjuvant. Remember, once we have invasive, we pretty much ignore anything in situ, which makes it very easy sometimes. Okay, so exercise 3. This case, the biopsy was invasive, but we don't have any residual in the lumpectomy. So for grade clinical, this would be a grade 2. Grade 2 for the path. Remember, we want the highest grade of the primary tumor that has been surgically resected without neoadjuvant therapy. The path grade includes any information from the clinical grade all the way through surgical staging. That is considered pathologic. Grade post therapy is blank because there's no neoadjuvant. And then note 9 tells us to use the grade from the clinical workup for the primary tumor when the surgical resection is done of the primary tumor and there's no residual carcinoma. So that's why we are allowed to bring that down. Now, if there was no lumpectomy or no surgical procedure, you cannot bring the clinical down to the path. There has to be a procedure done, even and if you don't have any residual or it's a less grade, you still are allowed to bring that clinical grade down. Okay, exercise 4. The core needle biopsy, we have a grade 1, and the mastectomy, we have a grade 1. So grade clinical is a 1, grade path is a 1, and grade post-therapy is blank, no neoadjuvant therapy. Okay, so here's a neoadjuvant example. Remember that the grade path records the highest path grade of primary tumor that has been surgically resected without neoadjuvant therapy. Since this patient had neoadjuvant therapy, no valid path grade can be recorded. And also, the grade path cannot be blank. So clinically, we know the grade was a 1, and then our grade path has to be a 9 because there was neoadjuvant therapy. Remember, for the grade post-therapy field, you cannot bring down the clinical grade, even if it would be higher. The notes tell us that the grade post-therapy is only after the completion of neoadjuvant therapy. So we do have a good text here. The Nottingham grade is 1 of 3. So grade post-therapy would be a 1. Also remember that when you're coding the clinical grade, you are limited strictly to the clinical time frame. So on this case, the clinical information we have is that this is a DCIS low grade. So we have to code the clinical to that DCIS. Remember, we have those 3 grade codes that are specific for in situ only. And then per clarification from the standard setters, which was Cancer Forum, when an in situ only is diagnosed in the clinical timeframe, but invasive diagnosis was in the pathological timeframe, code the grade of the in situ tumor in the clinical and code the grade of the invasive in the path grade. And that's exactly what we have here. So the lumpectomy showed invasive ductal intermediate grade or score 7 of 9. This case uses the term intermediate Nottingham, but it also gives you the score. So because the score is there, you can go back and use code 2 for grade path based on the score. If you didn't have the score and you had to use intermediate grade, you would go back to the grade generic table, and that would be intermediate would have been coded a B. Okay, grade post-therapy then is blank. So texting, if you have the score, Nottingham score 7, that is very good. Otherwise, you would have to go back and use that generic grade table to code it a B. There are exercises on SEER Educate for anyone that does the site training. These are excellent. The SSDIs just give you confidence. The grade homework just helps you walk through a lot of these different scenarios. So I encourage you to do that if you have time. And otherwise, if you have questions, please email me any comments or things that weren't clear in the presentation. Thanks for listening.